And again, welcome. My name is Jacqueline Dugan, and I'm supporting our speaker today, Dr. Pamela Scarborough. And again, we're just so glad you're here. This is our second session in this webinar series, and we're going to get started here in just a second. Quick reminder, chat is open. You can see everyone is introducing themselves. Also, feel free to put questions there anytime. I'll pause Pamela if there's something to address during the session. Otherwise, we will get to your questions at the end. I'll also be sharing a few helpful resources in the chat. Be on the lookout for that in just a minute. They'll go along with today's topic. And yes, the webinar is being recorded, so I will be sending out the replay to you all afterwards. And before we jump in, just in case you weren't able to join us last month, I'd love to introduce who we are at United Wound Healing and a couple of our key initiatives. United Wound Healing began in 2015 to bring expert wound care to patients right where they are instead of sending them out to outpatient centers. That small shift has made a big difference in comfort, outcomes, and costs. Today, we support over 400 partner facilities across 4 states. That's Utah, Washington, Idaho, and Oregon. And we provide wound care to more than 15,000 new patients every year. We're also advancing our field through open wound research, which makes high quality open source wound care data and tools available to clinicians and researchers. We're very excited about this, as well as our fellowship program, which is the first of its kind, designed to train advanced practice providers in wound care, dermatology, and limb preservation. So if that's something that you're interested in, I'll share a link to that later and you can check it out. Let's go ahead and get started here. I'll introduce Dr. Pamela Scarborough real quickly. Dr. Scarborough is the Director of Education in the Fellowship Program here at United Wound Healing. With over 40 years of experience as a physical therapist, she's a nationally recognized educator and founding faculty member of the Wound Certification Prep course, which she's taught for 2 decades. Her work today focuses on improving wound prevention and management outcomes in post-acute care. She's wonderful. You're going to love this presentation. Pamela, I will pass the mic over to you.
Thank you, Jacqueline. Very good job. Appreciate that. And thank you everyone for being here for the second of our 12-month curriculum. I just wanted to mention to you that if you stay with us for this 12 months, you will get a library of current either evidence-based clinical best practices, consensus statements on wound prevention and management, and or any updates in the regulations. Because when I teach specifically, more strongly even, to long-term care. Home health is right in there with us. The regulations for home health, the OASIS, which compares to the MDS Section M, they're very, very similar. So I'm very established in the post-acute care setting, primarily for independent living, long-term care, and home health. So what we do today, I have to read this. The information provided is for informational purposes only. Patient care decisions should be based on relevant clinical guidelines and including current evidence-based literature, which is part of why you're here. It's not just to listen to me talk. That's not as important as the things I leave behind for you. The PowerPoint presentation, 2 slides per page in color, so you can go back and teach others. I see that we have leadership on this call today. So the leadership, take this information and start your library for current evidence-based wound prevention and management. I even carve out the MDS and the Section M for you and the F686 out of the State Operations Manual, so you don't have to go through the whole document. So you stay with us for a year, you're going to have a library. So patient decisions should be based on relevant clinical guidelines, including current evidence-based literature, state and federal guidelines, and facility protocols. We might have some gaps, and we talked about last month. We talked about your wound prevention and management structure, your program. That's what we talked about last month. And if you missed last month, you really need, that's where you start. How is your program structured? That's where you look first. You don't look at this nurse that has their certification. You don't look at this doctor that's going to come in. You look at your prevention, pressure injury prevention, and wound management program in your building first. And that was the program we did last month. So if you weren't here last month, get with Jacqueline in the chat and give her the information so that she can help you get this information. You want all 12 months. And decisions for wound management should be based on a holistic review of the patient's clinical condition. The clinical team members are encouraged to rely on your training and expertise. Where did you get your training in wound management? This is a specialty, just like dermatology, orthopedics. This is it's called wound medicine. It's wound medicine. Wound care is what we do at the bedside. We do that debridement. We do that dressing change. That's wound care. This is wound medicine, and it takes looking at everything going on in that patient or that resident to understand how to take care of those wounds. So you want to rely on your training and expertise on how to do this, and we're going to give you some of that information. You're going to need to go further than this, as well as all available clinical and other pertinent information. You cannot rely on the Braden and the skin assessment by itself to tell you how at risk that person is for a pressure injury. If you're only using the Braden and you're only using the skin assessment, your pressure injury prevention program, wherever you are located, has already failed. You have to go way beyond that. All available clinical and other pertinent information prior to making treatment decisions for any individual patient. So the first step, and you will see when you work with me that in the left-hand corner oftentimes is the resource from which the statement came. Use this. If you've never heard this information before, you need to start verbalizing the things that I'm saying in your buildings to lead your team if you are a team leader. And if you're the clinicians, then you need to know this information because the surveyors know this information. You have the answer to the test. You have the questions to the test. The questions are in your clinical practice guideline for the prevention of pressure ulcer injuries. Those are the questions to the test. The answers are in F686. So, first step in preventing a pressure ulcer injury is to identify that resident and all of their risk factors. This is followed by implementation of appropriate individualized interventions. Surveyors don't want to see cookie cutter interventions unless the patients have the exact same situations, and they don't have the exact same situations. So you will have to individualize each of your care plan for the specific patients and residents. And monitor, that's where we break down. We're not monitoring closely enough. Do your CNAs know what to monitor for wound prevention and management? They are your eyes and ears. If your CNAs are not trained, and many of you in long-term care as nurses, you came up from CNAs, you know exactly what I'm talking about. If they are not trained to be your eyes and ears and don't know what to look for exactly, they can't help you. 70 to 80% on the task for preventing a pressure ulcer injury is on the shoulders of the CNA. Do they know everything that they need to know? So you need to take this information back, not just for your clinical team. Well, your CNA to me is a clinical team, but be sure that your CNAs are included. So you want to do your head-to-toe skin assessment plus your Braden. You want to do both of those and your other risk assessments. Look at your other risk assessment. So these assessments, the ability to do this, it requires clinical skills to know how to do this. They're critical for identifying your patients and residents that are at risk for pressure ulcers and other skin issues such as skin tears. When you're at risk for a pressure ulcer, that person is at risk for skin tears. When that person is at risk for skin tears, that person is at risk for a pressure ulcer. The two go hand in hand because a lot of times it has to do with mobility and handling of the people when we're looking at skin tears. So how do you ensure that your nurses are well educated? How do you, clinical team leaders, DNSs, DONs, ADONs, the education RN in your building, how do you ensure that your nurses are well educated in performing and competent in performing and documenting these processes that we're talking about? The intake process, where we're looking at everything, not just the Braden and the skin assessment. Competency, are you sure that nurse knows how to do the Braden? You need to watch your nurses do the Braden. I know I'm going to insult a lot of people. I'm so sorry. People insult me sometimes too, telling me what I can and can't do and shouldn't do. Return demonstration competency is important for when the surveyor is standing over the shoulders. You don't want to get nervous. And so competencies give you confidence in being able to do the dressing change, a clean dressing change under the pressure of the surveyor being over your shoulder. So competencies are not bad things. They're good things. And this is one of the documents, and we're gonna dive into. This came out a couple of years ago, and it is at-risk skin, 21 consistent statements for at-risk skin. And this is a document and a shorter document that you've been given. I suggest that you read both of them. So there are 21 statements in 7 different categories, and we're not going to do all of them. These are the 7 categories. I just carved out a few of them because we could do an hour and a half just on this document. And so you want to read it, you want to give it to your nurses, you want to go back and do a quiz on it. And if y'all want me to get you a quiz together, if you're going to use it, we'll get you a quiz together for this particular document. So category 1, at-risk skin, is defined as the potential for impaired barrier function of the skin due to associated intrinsic and extrinsic factors, conditions, and comorbidities. At-risk skin can happen in any stage of life, early in life with our neonates, advanced age, where we're working with, oftentimes in long-term care, advanced age, although the people have been getting younger and younger and younger. I've been in this industry for over 45 years, where I used to see 70, 80, 90-year-old people. Now I'm seeing 40, 50, 60, 70, 80, 90-year-old people in long-term care. And those 40, 50, 60-year-olds, they're sick as they can be. They're sicker than we've ever seen. And we are a step-down unit for acute care. We're taking care of people that we don't have the skill sets or the oversight by the medical team to be able to handle all of their conditions so we can have skin that's intact. So a lot of the things that you may be thinking that are being missed by your team, it's being missed by everybody, including the providers that got the people there in the first place. So you have to look at everything. Are at end of life. And some of the wounds that we are reporting as a pressure injury is truly an end of life wound. And we have a session on that later in this 12-month curriculum on the unavoidable pressure injury, skin failure, Trombley-Brennan terminal tissue injury. We have a whole hour on just that one topic. So recognition of the skin at risk. So the question is, who in your building does not have at-risk skin? That's the question. Anyone in your building who needs any assistance in getting out of bed and moving and walking and transferring have at-risk skin. Anyone who has immobility, be it chair mobility or bed mobility, immobility, has at-risk skin. Anyone who has 2 or more organs that are in failure has at-risk skin. So in F686, it talks about, well, one of the things I want to tell you is that skin health starts on admission, of course. So this is what F686 has to say about present on admission. This is as close to the actual time of admission as possible. So you're going to have to think about your weekend stuff. This person came in at 3 o'clock on Friday. You have 48 hours to get your basic care plan in place, which is going to be on a Sunday at 3 o'clock. So do you have the people also on the weekends that can help you with present on admission issues? Many of our over 100 pressure ulcer risk factors are the same for other skin at risk issues, such as skin tears. So was this person's skin problem when they came into your building, was it present on admission, or did it develop after admission? And some of the factors that are going to influence these, we want to identify the factors that are going to influence the development of pressure ulcer injuries or additional pressure ulcer injuries, or that cause the deterioration. Sometimes your wounds stall. That person's wound stalls. When those wounds stall, they're telling you they either have an infection, a blood flow issue, or some other comorbidity or organ issue is in failure and getting worse. When your wounds stall, get nervous. Don't think, oh, it's not getting any worse. It's not getting any better. It's not getting any worse. When it stalls, you want to start worrying. So all factors that lead to these wounds for not healing, for stalling, for getting bigger, for acquiring them in the first place, you want to look at all the risk factors that they need to be recognized, they need to be assessed, and they have to be addressed by your care plan. Any new facility-acquired pressure ulcer injury suggests a need to reevaluate the adequacy of the prevention measures in that resident's care plan, and you go back in your root cause analysis to figure out where your system broke down. In the first program, I explained to you, it's not that CNA, it's not that bedside nurse that caused any wound to fail, to be acquired. Your system failed, not your clinical team. Your system failed. Category 2 of these 7 categories says practice considerations for skin health or at-risk skin. So it says all persons should have an evaluation to determine if they have at-risk skin. Individuals who are mobile, which is the biggest part of what we have to be concerned about with people who are at risk for pressure injuries, is immobility. So you want to ask yourself, what caused the immobility in the first place? That's your culprit. That's your organ. What caused the immobility in the first place? Individuals who are more immobile and chronically ill are susceptible to developing at-risk skin, such as pressure injuries, incontinence-associated dermatitis, which is at the very bottom, skin tears, which is in the middle, intertriginous dermatitis. I'm sorry, that's at the very bottom. It's intertriginous dermatitis, which is inflammation of the skin folds. Oh, and here you go. Here's your pressure ulcer at the very top. So these are some of the conditions. These are all skin at risk issues. So the initial evaluation should be performed by a qualified healthcare provider or professional. Healthcare professional is the way it's listed in the literature. And so that is our whoever in your building can do an assessment process. LVNs, LPNs can do screening, just like my physical therapist assistant can do a screening. And then that information has to come back to me, and I have to do the assessments and the evaluations and write the care plans as a physical therapy care plan. So the RNs are going to have to do the assessments, some of the assessments, depending on your state practice act. And don't listen to me about your state practice act. I know about mine, and that's all I know. So you look at yours. We have to have these assessments, and we have to assess for skin color, visual changes in that area. If it's a light-skinned individual, such as myself, that area, if you're having erythema or inflammation, it's going to be kind of reddish or pink on me. On a darker-skinned individual, particularly when you get into the very dark skin tones, it's going to be a darker tone, subtle, darker tone of their normal skin tone, their inflammation. Skin turgor test, and the recommendation in general is that you do skin turgor on the between the eyebrow and at the clavicular clavicular notch, the forehead turgor, skin turgor, and if the skin comes together, you have severe dehydration. According to the literature, you would have to do lab values to see how bad the dehydration is. And we have to be very careful in our population with dehydration. We don't have a thirst mechanism. Older people don't have a thirst mechanism anymore. They can't even tell you they're thirsty. Temperature or erythema. You see a reddened area, the CNA sees a reddened area. The first thing they do is they report it to nursing. Report it to nursing. The moisture level, the subepidermal moisture, we're going to talk about that, and I'll introduce you to the provisio. And then you're looking for the skin integrity. Are there any open wounds? Are there blisters? Are there rashes? Do we have dermatological issues that we're going to be dealing with here? And so this person that's been identified with at-risk skin, they need to have this comprehensive initial evaluation and assessment and ongoing assessment. Anybody that comes into our building that is at risk is always at risk for pressure injuries in our buildings. Category care strategies that include prevention and risk mitigation should be put in place also. So a preventive skin care approach for at-risk skin is preferred rather than an after skin issues evolve and into a more serious skin issue. So these are some of the common risk factors that are mentioned in this article, and there are many, many, many more. I just pulled out a few of them. Over 65 years old. Yes, that's probably 70% or 80% of the people in your buildings. Cognitive impairments, you don't think about that as a risk factor for pressure injuries. It is. Endocrine disorders, you do know that diabetes is a risk factor for pressure injuries and other non-healing wounds. Keep that blood glucose under 200 milligrams per deciliter, and there's no such thing as a sliding scale anymore. Just take that back and go talk about it among yourselves. And we're going to talk about the wound etiologies in the next session or two, next month or two. Your history of cortisol, if you have anybody on corticosteroids, anybody on steroids, that stops the second phase of wound healing, which we're going to talk about as we go down the road. You have steroids, they stop the inflammatory phase of wound healing, which you need to prevent infections and to go into the proliferative and the healing phases of wound care. Steroids stop it, especially high doses of steroids, and we have people that have to be on their steroids. So to mitigate steroid use, the recommendation is to use oral vitamin A. Vitamin A. Then impaired mobility, that's the biggest one that you can see readily is this person isn't moving well, and you always want to know why aren't they moving well. That's the basis of what you need to know. Why aren't they moving well? Lack of sleep. We heal when we sleep. We heal when we sleep. And there are many, many more, including the use of medical devices and PPE. That's in there. And what that came out of was COVID-19. And it came out of is for our healthcare teams that were wearing their mask and they were getting wounds. So that's what the PPE is all about there. So you want to develop a protocol or process for screening and evaluation. When are you going to do it? And it's very clear when we do these assessments. We do it on admission, changes in condition, complaints by the residents, our MDS quarterly assessments, and we usually do the first 4 weeks in long-term care every week. We do the Braden every week for the first 4 weeks. And then unless there's changes, we go to quarterly. And anytime there's a change in condition, then we need to do another evaluation. And who's going to do this? This is going to be by your nurses. I can do a skin assessment. I'm educated to do a skin assessment. You said, Pamela, go do that skin assessment. You got it. I'm there. But because it's an assessment, it's going to need to be somebody that has a bachelor's degree in most instances, at least a bachelor's degree. You want to have skin issue recognition. Number one by that CNA. Number one by your CNA. Bring them up, lift them up, educate them up. They are one of the most important people in that building when it comes to preventing pressure injuries, or any other team members. And they need to be able to know what to report to nursing. How are you going to do this with visual inspection? You have to know what you're looking at. When it comes to wound management, wounds is a visual discipline. You have to know what you're looking at. The SEM, that stands for sub-epidermal moisture. If it's available, you're going to do that. It makes a difference. I'll tell you why in a few minutes. Consistent documentation of the skin care and the notations of any changes, and natural lighting. If you can get natural lighting, the lighting in our buildings are terrible. The lighting that we have is just terrible. I even have some of my older clinicians that will wear a headlight on their forehead, particularly when they're doing things like debridement, but sometimes even to look at the skin to have good lighting to see what they're looking at. So I want to mention to you and bring you up to speed on what's called the sub-epidermal moisture, SEM, sub-epidermal moisture. This is a device that was Barbara Bates Jensen did it. Dr. Bates Jensen out of California created this, and it's now on the market. They're using it a lot in Europe. We're using it some in the United States. And what it does, it measures the inflammatory edema. So look at this with me. We have this person where they are laying on their back, and you can tell on this Seymour butt model that you're having deformation here. So we have our patients and residents laying on their back. They get deformation of the soft tissue, and this deformation causes the cells to be crushed for if it's for a long period of time, not just crushed, but the blood flow is cut off at the superficial level. And so we have more swelling that takes place. We have and all of this takes place, and the person doesn't even have erythema, whether they have dark skin or light skin. You don't even see erythema yet. But if you use and there is edema taking place. So if you use this device right here, it will identify edema 5 days early. So I want you to think about the people that come into your building and they don't even have, you can't even see a stage 1 pressure injury, or it may be a stage one pressure injury present on admission. And 2 days later, it opens up. If you don't have this, no, that's not right. That's not how I want to say this. This person comes into your building, they don't have redness, you put this device on and you find that they have an area over the sacrum that is inflamed by the SEM machine has identified this inflammation. It'll identify the inflammation up to 5 days early. So this person was someplace else, they come to you, they have the redness, and 2 days later, this redness opens to a stage 2 pressure injury. Had you used this device, you could call that present on admission because it was present on admission. You just couldn't tell. So you have to think about, yes, it costs money, but what is it going to do on the other side, or where we don't have to spend money on F tags that we didn't deserve in the first place because it was present on admission, and we don't have the technology to recognize that until recently. And this is one of the tools. So, and it doesn't matter what the skin tone is either. That's the other thing about the Provisio. It doesn't matter what the skin tone is. So the device changes present on admission opportunities to pick up early pressure damage before it's even visually apparent. And this is this device. This is the Provisio. These are the 6 places I think you test. Yes, 6 on the sacrum. And you also test the heel, which is it's very interesting to me because I learned a couple of years ago about something called angiosomes and how that applies to pressure injuries, particularly at the sacrum and the heel. And the sacrum and the heel have very poor angiosomes. Angiosome is where the blood flow goes to the skin. When someone is doing, you have a plastic surgeon that's doing a flap, they take that source artery, they take the source artery that's going up to the capillaries, and then the capillaries they go into the skin and they spread out into what's called an angiosome. That's your capillary isn't the final, it's your angiosome that's the final to the skin. And any place along that major artery, source artery, capillary, any place that there is a blockage, you're not going to get blood flow. Now, the sacrum and the heel, where the buttocks have tons, like, I don't know, maybe 50 angiosomes on each buttock, 50 angiosomes. The sacrum has one on, and the blood flow, they have one angiosome on each side of the sacrum, and the same thing down at the heel. Very, very, very poor blood flow from the source arteries to the skin. That's part of why we have more sacral pressure injuries. We don't have good blood flow there to begin with. A lot of these people that we're putting on beds after we see that they're having skin issues, they needed to be on beds earlier. And this is one of the tools that'll help you figure that out. So moisture and their role in skin health for individuals with at-risk skin, creams or ointments are preferred. Creams or ointments to help decrease that transepidermal water loss. Lotions that have alcohol in them are going to be more drying, and so we try to stay away from those. So your stratum corneum, this is the top layer of the skin, and incontinence, the chemicals in incontinence destroys this top layer, just absolutely destroys it. So the one of the things that the stratum corneum, or the top layers of the skin, does is they minimize that transepidermal water loss, helps to limit the UV light that damages skin. It also has an immune function, and when that stratum corneum is damaged by things like incontinence, then you've lost some of your skin barrier protection to microorganisms also. So these cells, the stratum corneum cells, they last for about 2 weeks and then they shed. And then you also can get lymphatic impairments in here, and that's going to make things even worse. And we can end up with buildup of skin bacteria. We get skin neoplasms, and oftentimes we even get wound infections from some of the things that are changing. So moisturizers, they improve the skin barrier by reducing your water loss, improving the skin, improving and restoring the skin barrier function, and maintaining that lipid structure of that stratum corneum. You've got to have that lipid structure. And the types of products you want to use are emollients, humectants, and occlusives. I'm into taking care of my skin. I'm almost 74. I have great skin, I have to tell you. A part of it's heredity, part of it's staying out of the sun, part of it's not smoking, and the other part is using these products that keep the moisture in your skin and keep it supple and healthy. So benefits of moisturizers, the emollients, they're rich in this lipid content. They literally accelerate your skin barrier function, the healing of the skin barrier. They help restore the skin barrier function and adequate hydration. It's extremely important to prevent the recurrence of that skin damage, even when the symptoms have resolved. You cleaned up that moisture-associated skin damage, that MASD. You worked on it, you worked on it, you worked on it, but now you have to keep it strong and keep using your moisturizers. They don't go away once that MASD is cleaned up. So there are things we don't want to do. We don't want to use too much soap or have too much sun exposure, and smoking damages everything in the body. That's just another talk for another time. So this is just, I wanted to show you some of the products. So here's the category: emollient, humectant, the occlusive. These are the brands. I've pulled out some brand names for you. And then here are some of the key ingredients. Here's your emollient, your isopropyl palmate. Here's your emollient, dimethicone. Here's your humectant, urea. So these products are the products you're looking for in these different brands. And so these are some of the medical grade brands of skincare products that you might want to consider using. And category 4 of the 7 says practice considerations for moisturizers and skin barriers. For individuals with at-risk skin, a moisturizer should be put on daily. Every day, and always full body after bathing. Twice daily moisturizing, we have the literature that shows twice daily moisturizing has been demonstrated to show additional benefits. Typically, usually after when people are getting dressed in the mornings, the CNA may put on their creams to their arms, maybe their feet and their legs. But then after their shower or their bath, however they do it, they need to put it over the entire body. And the amount that they need to put on an average size adult is 30 grams or 1 ounce. All right, Pamela, you said 30 grams or 1 ounce. What does that look like? We're going to talk about that. So the total body surface area, this comes from the burn world where they talk about the total body surface area. The head is 9%, the front of the trunk is 18, back trunk 18, each arm 9, each leg 18%. It changes when it's babies, and it changes if you're morbidly obese. Things do change in the total body surface area. So skin barrier disruption is very early stages, may be invisible to the naked eye, and erythema does suggest that an inflammatory response has already occurred. Proper skincare should be initiated before the appearance of erythema, and skin disorders involving more than 10% of the body surface may be considered moderate to severe. And sometimes we get wounds that are just ginormous. They're so big sometimes. So I want you to look over here on this left arm. We'll say it's the left arm. It may be the right arm, but the arm on the left of your screen. And it says 9% because each arm is 9% of the total body surface area. So there was a study that was done, and that's this study down here. And in this study, they were looking at how much skin cream a group of facilities within a corporation was ordering. And what they found is, watch that left hand arm over there, that the study showed the facilities were only ordering enough cream to put on the forearm of each patient. That's all. So this study showed them how they were underutilizing the creams. Where are you? And how are they being utilized for prevention of skin cares and pressure injuries? So what this highlighted was the lack of awareness of the amounts required for effective skin moisturization. And this is what it is. This is travel toothpaste. This is a medicine cup, a packet of ketchup, 3 coffee creamers, or 2 tablespoons. Now, I don't know where they got these numbers, but I'm just talking to you out of the document. The 30 grams should be applied to it. This is the standard size adult body. I'm a standard size body. Actually, if I weighed 170, I would be obese. I'm 5'3", and I weigh 130. So to me, 175-3 person is not an average female, but I wouldn't write in the document. So this is, and there will be people that are going to be larger, and you're going to have to use more, but it needs to go over the entire body. So the Braden is a component of the pressure ulcer risk assessment. It's only part of the pressure ulcer risk assessment. You have to look at all the risks, specifically the organs and organ system impairments. So the surveyors, they recognize the kidney terminal ulcer. CMS recognizes the kidney terminal ulcer, which is also known as skin failure. But to be able to call something skin failure or a kidney terminal ulcer, you have to show that you have care plan for every single risk factor. Otherwise, how can you tell them that this is a pressure ulcer? It's not a pressure, excuse me. How can you tell them it's not a pressure ulcer if you haven't care plan for all the pressure ulcer risk that that person has? So you have to address the risk before they develop a pressure ulcer. And it starts with looking at the systems. It starts with the head to toe skin assessment. It starts with the Braden, and then you go to the systems. I might do the systems before I even do the Braden. So you want to remember that the presence of a hard, chronic, hard to heal or non-healing wound, it's a symptom of failing physiology. What's failing in that body documents what's failing, so you can have that unavoidability designation when you want to say, surveyor, I don't think this is a pressure injury. I think it's an end of life skin failure, and this is why. And you can show them the ABI is this. This person this isn't in a pressure area. You go through all the reasons this is not a pressure injury. I was talking to a group yesterday. Was it yesterday or day before yesterday? And I was saying, prove it is a pressure injury. We're reporting things that aren't pressure injuries. So I think we need to prove things are a pressure injury before we report them as a pressure injury. You don't know the etiology of the wound, this is the other thing that happens. You don't know the etiology of the wound, don't say it's a pressure injury. Do not default to pressure as an etiology unless you absolutely know it's from pressure. You want to document everything that's failing in that body. That's part of your pressure ulcer injury. and skin health and prevention risk assessment is to look at all of the organs. So we have over 100 we have over 100 risk factors. We have 11 organ systems, and every one of them affects the skin. That's why all of these arrows are going to the skin. So our tissue oxygenation, we have to have that for good skin tolerance to pressure and shear forces. Your cardiac failure and respiratory failure play a part with reduced oxygen supply and delayed reactive hyperemia, accelerated vascular occlusion. Renal and liver failure results in alteration in cellular nutrition and waste transport. Liver failure. You will not get protein synthesis when you are into severe liver failure by your residents. Protein synthesis stops. You've got to look at all of these organs. Your immune system creates risk for skin. Do they have low immunity? The musculoskeletal system is going to have impairments for mobility, certainly, but the skeletal system, that's where some of your red blood cells come from. Do they have anemia? If you have anemia, you're between a rock and a hard place. If your patient or resident has anemia, they don't have enough oxygen carrying capacity. So that's your lab values. Now you're looking at your lab values. Do they have digestive system issues with their mouth, their stomach, their small or large intestines, their liver, their gallbladder, or their pancreas? Any of these are going, any of these are failing, it's going to have more risk for wounds or pressure injuries in the person that's immobile, and have issues with healing also. And then the nervous system, the sensory nervous system, the motor system, the autonomic nervous system, the brain and the peripheral sensory damage, all the diseases that can upset the skin milieu and what the skin needs, the strokes, the neurodegenerative diseases such as multiple sclerosis and amyotrophic lateral sclerosis, Lou Gehrig's disease. So CMS, they list a few of the risks. This is in F686 State Operations Manual, and it says impaired mobility. We got that. But what caused the mobility? So that's the next thing CMS talks about is the comorbidities. And this is where I see the biggest hole in our assessment processes in home health and long-term care. They do a better job of it in the outpatient wound care centers for some reason, and they do a much better job, of course, in acute care. So the comorbidities are not being picked up, and I'm hearing reasons why the hospital didn't send us this information. The hospital didn't do this. The hospital didn't do that. Well, then you've got to do it. If you don't have the information to determine whether that person's body can heal a present on admission wound or not, then you're going to have your medical providers, your medical directors in your building to be part of the solution, or that person's primary care physicians. Drugs, we've already talked about steroids. Anticoagulants are another one that's a problem. Impaired diffuse oxygenation. Impaired diffuse oxygenation, pulse ox, pulse ox, pulse ox. If that pulse ox gets below 90, you get down to 88, 86, you're going to have problems with wound healing, no matter what the wound etiology is. And then local blood flow, that's looking at peripheral arterial disease. And oh my, we are seeing so much PAD, so much peripheral arterial disease in our buildings right now. It makes my head spin. I've never seen anything like this, and I've seen it worse since COVID. And I don't know if some of these are residual things from COVID, from the cytokine storm that caused all the coagulopathy issues that we saw in 2020, 2021, and 2022. So I'm not sure if that's what it is, but what I can tell you, unequivocally, and I talked to a lot of providers around this country, we're seeing more lower extremity peripheral arterial disease than we have ever seen in our care setting. Just be aware and be prepared. Refusal of care, yes, they can refuse, just document, document, document. Then we have sensory perception. And this is on the Braden, of course. And when you do your sensory perception, you don't ask them if they can feel anything. You use a monofilament. You don't use a sharp pen to do sharp, dull. I know that's something that everybody thinks we should do, but you don't do sharp pens because we have so many people in our building with diabetes. They don't feel it. And providers clinicians are, sometimes they push harder. You didn't feel that? See if you feel this. So we don't use sharp pens on people to identify neuropathy. There are other tools that we can use. Cognitive impairment, I've already mentioned to you. That is a risk factor for pressure injuries. Nutrition, hydration, we get that. Changing condition, whatever it is, you got to go back and figure out what happened. Now, a previously healed pressure ulcer injury is always at risk for reopening with less pressure, less comorbidities, less issues. And a stage 3 or 4, I'm talking about 3 or 4 pressure injury. Is always going to be whatever its last deepest stage was. It was a deep stage 3, or it was all the way down to muscle, bone, and joint. So it's a stage 4. That will always be a stage 4. You do not backstage. And I think we know that now. So other recognized risk factors: underweight, and the higher risk for pressure ulcer than obese or normal weight. Underweight is a higher risk for pressure ulcers. They have no padding. They have no adipose tissue to protect their bony prominences. And you never put anybody on a diet when they're trying to heal a wound. Also, if they're losing weight, you're not going to get wound healing. You've got to watch the weight, nurses. You have to watch the weight, and that's your CNA again. They need to be taking the weight. You do not want people losing weight when you're trying to close a wound and get protein synthesis. Low hemoglobin, I just mentioned that to you. You don't have enough oxygen to carry to your organs, including the skin, which is at the terminal. All the skin is the terminal part of the highway for blood flow. That's where it stops. Everything gets its oxygen before the skin gets its oxygen. So people with low hemoglobin, the oxygen can't be carried to the organs or to the skin. People with multiple systemic diseases, each organ in failure compromises the skin. Each organ in failure, multi-organ failure, contributes to skin failure. Diabetes is the biggest risk for stage 3 and 4 pressure injuries. Oops, excuse me. Hypotension, we have to look at blood pressure. I'll talk about that some more in just a minute. Moisture, you have to keep that that skin dry when it gets moist, and we have moisture-associated skin damage even before we have MASD. When it's moist and warm, moist skin and increased body temperature, the moisture and the heat together, the heat specifically damages the collagen strands. That's why that turning that your CNA does when that CNA turns that person from their back to their side, it's not just taking the pressure off of the back, it's also trying to let that back cool. All of that skin, the buttocks, the sacrum, cool down because the collagen strands are getting weaker. There is so much science to all of this, nurses. There is so much science to this. And my concern is that the science is not getting down to the people that need the information. And that's why you're being taught like this today. So you want to check your oxygen level on admission, and anytime those wounds are stalling, I would do oxygen pulse ox every day. I'm hoping that you're doing pulse oxes every day. And and be sure when you put the pulse ox on, be sure you put it on correctly. That's important too. So, clinical tip, check that oxygen levels on all patients and residents, especially those who've had COVID. And I was just talking to somebody yesterday, and they had somebody with COVID in their building, and they were, one of the providers, and of course wearing their mask. If they're having COVID, now the cytokine storm and the coagulopathy issues are not as severe as they were in the first version of COVID-19. It's decreased. We're not trying to kill the host anymore. We're figuring this out. The disease is saying. So we're not having as many, but previously we were having a lot of low oxygen levels during COVID. Any form of heart disease, such as congestive heart failure. Do you know what the ejection fraction is for that person with with congestive heart failure? If you don't know, then you don't know how much blood is getting to the skin. Cardiomyopathy, pulmonary or cardiopulmonary, all of these diseases are going to decrease the systemic oxygenation. So this decreased systemic oxygenation puts that patient or level at higher risk for pressure injuries and skin tears. Let me go back to this. What diminished systemic oxygen levels also delays or prevents wound closure. Now we're going to talk about the Braden. So if we only use the Braden in the risk assessment tool, we're not going to pick up all of the pressure ulcer risk factors. In F686, it says, although the requirements do not mandate the use of any tool, you don't have to use the Braden. CMS never said you had to use the Braden. I have a company in California that they threw the Braden out. They said, we have a $3 million lawsuit because of the Braden. It's not why they had a $3 million lawsuit. They did have a $3 million lawsuit because the nurses didn't know how to do the Braden and didn't know how to look at all the other risk factors. So don't blame the Braden. It's not the Braden's fault. So CMS, although the requirement does not mandate the use of any specific tool other than the resident assessment instrument. Many, actually there's 3, validated instruments are available to aid in the assessing, or as aid in assessing of for risk factors for developing pressure ulcer injuries. So we have to use the RAI. Now, this is interesting to me. And as I know more about this, this next statement is quite old. And at this point, research has shown, this was several years ago, that in skilled nursing facilities, long-term care, 80% of the pressure ulcer injuries develop within 2 weeks of admission, and 96 develop within 3 weeks of admission. So my question is always, how many of these were present on admission and the clinical team didn't know because they didn't have all the tools they needed? So that's how I think now. In F686, CMS knows we're not using the Braden correctly. And I know y'all are sitting there saying, what the heck is she talking about? I'm going to get there. CMS knows we're not doing the Braden correctly also. And says, regardless of any resident's total risk score from your subscores that you're going to add up, your 6 subscores on an assessment tool, such as the Braden or the Gosnell, clinicians are responsible for evaluating each existing and potential risk factor for developing a pressure injury and determining the resident's overall risk. And it goes on to say, because CMS knows more about the Braden than we do, it is acceptable if clinician's assessment places the resident at a higher risk level than the overall score of the assessment because we didn't do the assessment correctly, based on the assessment factors that are not captured. These are the other things that are not in the Braden by the tool. Documentation of the clinician's decision should be placed in the medical record. Why did you advance their risk? So these are the numbers. You know the subscores. This is at risk 15 to 18, moderate risk 13 to 14, high risk 10 to 12, and very high risk 9 or below. So let's look at this. This is a document that you've been given. This is how nurses are supposed to score the Braden. She gave, and each one of these I put in red for you what it correlates to. So sensory perception, if they don't have sensory perception, it correlates to a predisposed to intense pressure and not able to feel it. If they have moisture, that predisposes that person to have their tissue tolerance. We talked about moisture and heat a few minutes ago. So that affects tissue tolerance. Activity, if they don't have good activity, they're not moving around, that predisposes to pressure. Mobility predisposes to pressure, lack of it. Nutrition affects tissue tolerance, and friction and shear affects tissue tolerance. So this is how you're supposed to score the Braden, nurses. And if you've never seen this, you are not scoring the Braden correctly unless you had a nurse that taught you and mentored you from this document and from another one I'm going to show you in just a moment. So these are your 6 Braden parameters. Mobility is everything else is a contributing factor. Immobility is the reason we finally get a pressure injury. What caused the mobility in the first place? And you want to try to create a culture of mobility in your building as much as you can. When you look at your mobility nurses, when you're assessing your mobility, when you're giving the information to the MDS coordinator, or the MDS coordinator may be doing this assessment, not sure. A lot of times they're RNs and they do the assessment. So after comorbidities, so after you get those comorbidities, assessing accurate for mobility impairments and implementing a mobility plan of care is one of the most important components of a pressure ulcer injury prevention program. So you want to look at their bed mobility. Can they roll side to side? Can they hold themselves in a sideline position? Can they scoot up in bed when you put the head of the bed down? Can they scoot up, or do you have to help them scoot up? If you have to help them scoot up, there's a mobility issue. Lying and going from lying to sitting, going from sit to stand. You have to see them do this. MDS coordinators, you don't get to ask the CNA how they think this is done because there is an objective measurement for doing this that should be done on the RA from the RAI, and that's your GG mobility scoring. Just when and all of this is innate to physical therapy. In some of our buildings, the physical therapists are doing this, which is great. Let the PTs do it. Get them involved in your wound prevention and management. They need to be involved. They should be involved. They bring a lot to the table that's being left out. So again, roll right to left. Come up to sitting, lying, sitting on the side of the bed, sit to stand, chair to stand, toilet transfer, tub transfer. And this gets down, and which we always do, how many feet can they walk without getting short of breath, and what's their gait look like? Here's 10 feet, 50 feet, 150 feet. And then we have to make sure that we have the right equipment. If something's missing, oh, there it is. Then we have to make sure that we have equipment for people who have immobility, and we have to teach our people in the building, CNAs, nurses, the therapists oftentimes teach this on how to use this equipment. Hoyer, sliding boards, trapeze, going from sit to stand, using a pole, gait belt. Always use a gait belt, nurses, if you get anybody up. Sometimes they don't want it, but you have to do it for safety. We have accidents. If you have your gait belt on and there's a lawsuit, that's going to be less of an exposure for the building. Anytime you get someone up that has any mobility issues and cannot get themselves up, they need to be on, have their gait belt on. I would leave gait belts on my patients if I was going to see them 2 or 3 times, and I knew the CNAs needed to get them up several times a day. Sometimes some of the people had their own gait belts, is what I'm trying to say, and we would leave the gait belt on them for the day. No, we'll have fewer arm, hand, skin tears when we're using gait belts consistently, promise you. And the clinicians should be, and the staff should be trained in how to use this equipment safely and effectively, and competencies should be done. This is the mobility scoring that we should be using. And you cannot score this. You can't tell partial or moderate assistant. The helper does less than half the effort. Helper lifts, holds, and supports the trunks or limbs, but provides less than half of the effort. Is this what's happening in your buildings? If it's not, then your mobility assessment has failed, unless your therapists are involved. And in the Braden, it says, if other major risk factors are present, this is where we're missing it, the biggest place we're missing it, nurses. This is where you're missing it, the biggest place you're missing. If other major risk factors are present, such as advanced age, fever. When there's fever, the fever is using up the oxygen that we need for wound healing. Poor dietary intake of protein. These people are protein deficient. Almost everything you give them needs to have a protein supplement, especially when they're trying to close wounds. A diastolic blood pressure of less than 60 millimeters of mercury. Are you watching that blood pressure? Or a systolic blood pressure of less than 100 millimeters of mercury, which means that the capillary closing pressure is very low and it takes very little pressure to close those capillaries, affecting the skin. And any other hemodynamic instability, this is what you were supposed to do, nurses. Listen to this, please, 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 I'm begging you. Advance to the next level of risk. If you gave them a moderate risk, your scores, your 6 Braden scores, you get moderate risk, and they have congestive heart failure, whether you know what the ejection fraction is or not, you go to the next level of risk. If their if their blood pressure is low like this, you go to the next level of risk. This is in Barbara Braden's original documents, and here it is right here. You have been provided these documents. Jacqueline's going to make sure y'all get these documents. So this is at-risk skin of 15 to 18. If you have any other of these risk factors, it says any other major risk factors, such as advanced age, fever, poor dietary intake of protein, a diastolic blood pressure than 60 millimeters of mercury. Now, I went back and it took me several years to finally find, and I have it right here, hypotension is a risk factor for new pressure ulcer occurrence in older patients after admission. This says to an acute care hospital. It's going to be for any care setting. It doesn't matter where it is. So I finally found an article that talks about 100 millimeters systolically, if it's down that low. So you and your CNAs, y'all need to really pay attention to this blood pressure. This is an important slide. Comorbidities most associated with the pressure ulcer injury development is diabetes, stroke, and advanced dementia. Seems to be the most strongly associated for pressure ulcer development. Immobility in patients with a low BMI. These are your skinny minis. You think, oh, they don't weigh very much. They're not getting pressure injury. They're the first ones to get it. Watch that scapula, sacrum, iliac crest, trochanters. This is where our skinny minis get them first. If they have low albumin or hemoglobin, and I didn't spell hemoglobin, this is from a European paper. They spell things differently than we do. Low albumin or hemoglobin, do they have enough oxygen carrying capacity? Do they have enough red blood cells with the hemoglobin nicely saturated? Let's see, do they have high inflammatory markers? Inflammation, high inflammatory markers is a risk factor for pressure injuries and other types of wound issues. So any hemodynamic instability, such as low cardiac output, well, you're not going to know what the cardiac output is unless you ask for ejection fractions for people who are in congestive heart failure. Hypotension, there it is, hypotension, and chronic complications may be most likely lead to an unavoidable pressure ulcer. I don't think I gave you this particular document. Any documents that y'all see when you go back through this, because I put a lot of things in the resources. When this happens, just let me know. So a pressure injury, we should prevent pressure injuries. We have to prevent them. That is our mandate. We need to implement, monitor, and modify the interventions to stabilize, reduce, and remove the underlying risk factors. In F686, excuse me, pardon me, in F658, if the surveyor finds that you are not, are the building's providers, if our providers aren't following the standards of practice for wound management, then you can get an F tag. And all of my providers understand very clearly, if they're working with you, that if they cause an F tag, that we're all going to have a talk about what's going on. So you don't want the providers, whoever comes into your buildings. And I love mobile providers. I hope everybody has a provider oversight in your buildings for wound management, unless your medical directors are going to do that for you. Um, so the practice standards is that we provide the care that to prevent pressure injuries, and that we put in the wound management to heal the pressure injuries. And you want to ensure that you and your associates and consultants are delivering the current standards of assessment and treatments. And F686 ties to F658 ties to all the F tags, including F686. So section M gives you excellent. This is another thing. You have a new nurse. They don't know anything about our care setting, and they're going to have wounds. Promise you, you're all going to have wounds. You have more wounds now than you know what to do with, probably. So you need to teach from the MDS and from F686. So for the purpose of coding, determine that the lesion being assessed is primarily the result of a pressure, and that other conditions have been ruled out. If pressure is not the primary cause, do not call it a pressure injury. CMS is telling us this over and over. Don't call it a pressure injury unless it really is a pressure injury. Recognizing the ICD conditions that increase that pressure ulcer injury risk or risk for a Kennedy terminal ulcer or skin failure is a core component of the pressure ulcer risk assessment. So did you pick up every ICD-10 code? Some pressure injury prevention strategies. This is saying that you determined that this person was at risk for pressure injury. Just because you say they're at risk for pressure injury and they get one, doesn't mean you're out of an F tag. You said there was a risk for pressure injury. Did you care plan for every single risk? That's how you get out of calling it a facility-acquired pressure injury and calling it, per CMS right now, an unavoidable pressure ulcer, per CMS. The MDS says these are not pressure injuries. They say this is not pressure injuries. So F686, again, you want to know the clinical conditions that demonstrated that they were unavoidable, that these pressure, what you're calling a pressure injury, is unavoidable. You have to have documented those clinical conditions. So in summary, at-risk skin and pressure ulcer risk assessments must be comprehensive. Who are your team members who are educated and trained in assessing skin health and skin and pressure ulcer risk? Think organ systems. Every organ system is associated with the skin. Review the comorbidities and lab values, nurses. Tissue injury will usually result from organ failure in combination with immobility or medical devices. And this is in the literature. Which organs are in failure with your residents? Why are they in your building? There's more than 100 risk factors. Comorbidity listed. Now, this is from an article. Comorbidities is listing as causing more pressure injuries include diabetes, infection, peripheral arterial disease, cardiovascular disease, anemia, hypotension, advanced AIDS, vasopressor medication, which is going to lower the blood pressure, and many, many more, affirming the multifactorial etiology of pressure ulcer development related to the organs. Research, literature, and experience of clinicians over decades agrees that all pressure ulcer injuries are not preventable. Does your pressure ulcer injury and skin assessments clearly indicate the true level of risk for each resident for pressure injuries or non-healing wounds? Pressure injury prevention and wound management requires specific ongoing education to do well in any care setting. Consider wound management is a specialty. I already said that, just like orthopedics, cardiology, and requires another body of knowledge and skill to do well. Do you have the people in your facilities that are educated and skilled in this specialty area? Not just your visiting providers. That's not enough. Your CNAs, your nurses, your medical director, your therapist, your dietary team, all of us working together is the only way we're going to be successful, ladies and gentlemen. The only way. What did you hear? Thank you. We have 2 minutes. Did y'all hear anything that was meaningful to you? Do you have any questions? I'm looking at the chat right now. It's over here on this. Let me bring it over here so I can look at y'all. Let me see what we have in the chat. Nope, got to put it over here on my big monitor so I can see it. All right. Well, I can get it over there. There we go. All right. So, oh, somebody wants a quiz. All right. So we need to do this. All right. Let's see. Okay, several quiz. You want to get a quiz? Absolutely. I love making quiz for y'all. This is wonderful. All right. Jacqueline said you got it. Perfect. Are we able to access these recordings to use it? Yes, yes, yes. Please, please use them with your staff. Please. Oh yes. Okay. Thank you, Jacqueline. Oh, Jacqueline's taking care of all of this stuff. What tool? What's the cost of the Provisio? I don't know. I'm sorry. I should figure that out. Jacqueline, let's put that on our list. And if we can figure out who this is, maybe we can send them some information. Oh, no, you did it. She's so good. Y'all can see why Jacqueline takes good care of me. I mean, I think she takes great care of me. Thank you. We're going to see you next month. And what are we going to do next month, Jacqueline? Do you know off the top of your head? Is it wound etiologies, maybe?
Yes, wound etiologies next
Okay.
month. In fact, if you want to click over there, well, I have a quick summary slide there, and I will
Oh, yeah, yeah, yeah. Thank you. Thank you.
the
So,
I will,
wound etiology overview. Wonderful.
yes, and
Hey,
actually, I'm dropping the registration in the chat. If you
okay.
know that you want to come and want to see the next one, we'd love to see you there.
And it's fun. We're doing wound etiologies next. And if you can, it really is relevant for your CNAs. If any of you have CNAs that can show up, usually they're working so hard they can't show up. Thank you, thank you, thank you. And see you next month.